Thank you so much, Patricia, for being with us.
Well, you're welcome. I'm looking forward to it.
Well, since you already did an interview with David at Shrink Rap Radio talking about your last book about
Yes.
maximizing effectiveness in dynamic psychotherapy, I was wanting to shift gears and talk a little bit more about you and your own development. So maybe you could first tell us a little bit about your first psychoanalytic background before ISTDP. How did it happen? How was that experience for you?
Well, I think we have to go back even farther
Great, let's do it.
because, of course, why become a psychologist and why a psychodynamic, psychoanalytic one who wants to dive deep and get to these issues below the surface. So I think I was raised in an environment that primed me for that, actually. So I'm one of 5 children. I'm right in the middle. Irish Catholic, older brother and sister, younger brother and sister, and, intact family, mom and dad. And my mother was an extraordinary woman, brilliant in so many ways, but also mercurial. And we didn't find out until later in life that she truly had bipolar illness. And her father, my grandfather, had experienced way long ago very serious depression. Really sounded almost catatonic, like he couldn't get out of bed
Mm-hmm.
of days. And so finally he was actually hospitalized. And in those days, it was before ECT, they did insulin shock. But lo and behold, I mean, they did that and he recovered.
Aha.
Okay, but anyway, so growing up with a mother who was erratic, now it's interesting, of course, none of my other siblings have any interest whatsoever in anything psychological. I mean, they're all very successful business people, sort of maybe more identified with my father. Anyway, given who I was, and who knows, I also think, we have a purpose on this earth, and it certainly was mine. And this was a good training ground. So, of course, I became very interested in trying to understand her and what was happening to her.
Aha.
Why these things. So I think, when I look back, I went to this all-girls Catholic high school, which was very academically rigorous. And we actually had to write like a thesis paper. And what did I choose? I chose to write something on manic depressive illness. So interesting, long before my mother was ever diagnosed, but clearly I was interested in that. And yet at the same time, I was also very creative and artistic. And my father actually wanted an artist in the family. So he was pushing me to do that. So when I started university, I was studying art, but then I had to take other things, of course, and Psychology 101. Well, that was it. I mean, I thought, this is me, and this is what I want to do. And we had in that university an honors college. So it really was the best of both worlds. You had the access to the university, but this small college that was very seminar based. And so I just dove into psychology, right away. And again, just was always interested in what's going on beneath the surface that's not so obvious. So, I mean, I was reading Freud, of course, and then when I decided, which was clear really from about the time I was 16, I said, oh, I'm going to be a clinical psychologist. I mean, what did I know about what that was? I what I did, but I just knew, like instinctively in my bones. And even other people would say, well, you can't do that. I think you have to have a PhD for that. I said, yeah, but I think I will. I mean, nobody in my family believed in me in this way. But luckily, I had professors who did, and they really supported me. So when I was looking for PhD programs, I very much would only apply to programs that had a good psychodynamic background. I mean, of course, you got access to other things, but at least in those days, places were either behavioral, stony, or they were more psychodynamic. So, I mean, I just knew that's what I wanted, and just got deeper and deeper into it over time.
And in this phase, was there any particular author or book that really catched your attention?
Yeah, well, so I would say, again, we started with, um, and then we also had a lot of work and practice on assessment and the psychodynamic focus, even with using the WACE and other things like intelligence tests, as well as the TAT, and of course the Rorschach and Exner's whole system. And so I think getting really grounded in assessment was very important to me. And Rappaport, Gillen, Schaefer, and all these folks who really talked about doing and how to do a really good, thorough psychodynamic assessment. So I think in those days, that's what I was really focused on. And then when I did my residency at Northwestern in Chicago, they were very heavily influenced by the British school. So that's where I dove into Klein and Fairbairn, Winnicott, Guntrip. Just loved that because we were also treating more seriously disturbed patients, which, that sort of the British school was interested in doing. So those were, and of course, again, earlier, Fenichel, Ralph Greenson, all sort of the classic texts, Charles Brenner, and even some Ego, Blank and Blank, things like that. But I think, when I went to Chicago, we really dove into the British school.
And how do you remember the practice piece when you started actually practicing?
Yeah, so the practice was pretty traditional in a sense of doing longer term treatment. I saw patients 2 and 3 times a week. And actually, I also, when I was a resident, was working on an inpatient unit for adolescents. And there we saw patients 5 times a week. And I think, really my mentor, in a way, guardian angel, was Frida from Reichman. So right there, again, doing intensive psychodynamic work with patients. Like, again, I had a young man I was treating there who was, could get psychotic. And, doing this 5 times a week, largely interpretive, pretty traditional. But, it's so interesting when I look back on old notes or even some of the early papers I wrote, I was definitely focused on emotion, defense work. I keep thinking, I only really learned that when I got to Davenlo, but it isn't true. I mean, maybe a systematic way of working with it, but I was still
it was already there. Yeah.
Very interested in and focusing a lot on emotion and what's happening to the emotion and the defenses that are blocking it. And yet at the same time, I remember feeling quite, helpless in a way about, I would see it happening in front of me, the person defending against their feelings. But other than interpreting, I didn't have tools to help them with it.
So can you tell us a little bit more about what you felt were I don't know what you call them, limitations, but what you felt were your own personal frustrations with what you were doing?
Yes. Again, with some patients, I was very successful and got, some deep and lasting change. But these were people, again, who were, for one reason or another, very open to me and to what I was offering. But when I got those defenses that operated as a resistance, when it was kind of the wall, I felt like my interpretations were very accurate and profound, and yet it would have no impact whatsoever.
Why doesn't it work? Yeah.
Right. I mean, bouncing right off the wall of defense. Or where there are two people I really remember from this early time in Chicago. And this one fellow, he had, his problem was commitment with women. And he might be in love with someone and have sort of a primary relationship, but then he was always screwing around on the side and always had someone in his back pocket. And why was this? And why was he so terrified? And all of this? Well, both of his parents had died when he was relatively young, like 10 and then 12, something like that. So we knew it had to do with this, his terror of really attaching, because that would set him up for loss. So he was always hedging his bets. And so we knew this, we agreed about it. And yet what was really being avoided was all the feeling about these deaths. And when it would begin to come up, he would say, you know what, we just can't go there. If I start crying, I will never stop. And I didn't know what to do with that at that time. Yeah. I mean, now I would just say, really? I mean, has that ever happened? You eventually stop crying, right? But I was just hamstrung by it. And because we just didn't have those tools, no kind of challenge to the defense, right?
So translating it in maybe another way, do you believe that maybe that more traditional psychoanalytic approach we're doing could mostly stay at a more cognitive level, more meaning level?
No. It can go extremely deep and be utterly transforming. But what we know from most of the research, from Menninger, from Alexander and French, is that it's only about 20% of our patients who are, again, open enough to make use. Right. This works. So the other 80% of our patients, certainly this is true in the U.S., also have character problems, right? Character defenses that keep them cut off from their deepest feelings and keep others at a certain distance. It's with these people that interpretation alone doesn't work. And that's where, after 8 years of doing this, I was getting frustrated because I didn't have the tools to really help that other.
That's many years to be frustrated. Yeah.
Yes, it is. And so when I suddenly came on, Davenlou's work, which really is targeting that 80%, and doing all this pre-interpretive work on the defense and resistance so that patients can become available, right, to the deeper work. So it's not that traditional can't work. It certainly can and does, but with a small percentage of the population.
When was the first time you heard the name Habib Davenloux?
Yeah, that's a good question, because I swear to you, I heard about him in graduate school, and I can still remember, in fact, even seeing a videotape of him in his white coat in those days, and it had to be bootlegged because he would never allow tapes out there. I don't know how I saw it.
Wow.
Either there or in my residency, but I know I saw him. There's no question about it.
That's a beautiful story. And what was the impact?
Well, again, both sort of, when you first see him, it's kind of this amazing to see really for the first time the unconscious crack open in the most unmistakable way, with de-repression of memories, making sense of the current problem, the patient making all their own links. I mean, I had simply never seen anything like it. So I was very impressed, and yet it was also a little intimidating or scary, both the way he had to be to get there. And again, it was just this little thing, and it didn't really register. So it wasn't until these many years later when I just happened to move to Canada, and I just happened to get a flyer in the mail saying that this guy Evoluh was going to be in Toronto doing a 2-day workshop. And so I signed up and went. And then after 16 hours of sitting in a dark auditorium watching one breakthrough of the unconscious after another, it was just no contest. I mean, that's the way I had to go.
So maybe for people who don't actually know Evoluh, could you just briefly tell us a little bit who he is?
Yes. So Habib Evoluh is a psychiatrist. He is originally from Iran. He's Persian. He came to the United States to do a residency in surgery. He was originally training as a surgeon. And then in these days, in the 50s and 60s, I guess, was really the heyday of psychoanalysis, where all the best and the brightest were going into psychiatry. And so he got interested in this and he switched. So he started to study psychiatry and then became a psychoanalyst. He actually went to the Boston Psychoanalytic Institute, which was a very, we could say, conservative institute, very Freudian. And so, of course, he also had to have his own analysis. And it was the joint experience, he says, of both trying to practice this and having experienced it, where he ran into that same frustration that he knew this theory was the most powerful theory of the mind that we had so far, and yet the tools to really make use of it were still quite crude and had not advanced the way Freud even said, look, you're going to have to do this now. I mean, I discovered the unconscious. You have to figure out how to work with it therapeutically. But also, interestingly, in some ways, Evoluh went back to the way that Freud worked. People don't realize Freud was a short-term intensive therapist. The longest treatment he ever did was 6 months. He cured Mahler of impotence in a 4 to 6 hour, walk, doing intensive work. He was much more direct about defenses, and it's funny, it sort of got watered down, I think, over time, but in some ways it was going back to that. And then he also, so after he had this sort of dual experience of frustration as a therapist and also as a patient, he tells about the day it happened. So he was lying on the couch as usual every day in his analysis, free associating as he was supposed to do. And then his analyst, who had this habit of actually picking up the telephone when it rang during his session. I mean, he would usually pick it up and just say later or something like that. Back. But he would actually pick up the phone. And Evoluh realized he was increasingly irritated about this. And then this one day, the analyst picks and actually starts a conversation. And he said, oh my goodness. I mean, he just felt a rage welling up within him about this. And when the analyst put the phone down, he said, but then, of course, in the face of my rage, he said, of course, I simply went, no way I'm talking to him. And he just remained silent. And then he said, but then the analyst also remained silent. And I lay there and he sit there for 20 minutes, silent. And then at the end he said, tomorrow. And he said he walked out of there just fuming. And he thought, what a waste. I mean, my rage was right there on this. All he had to do was ask me about it. And that's where he realized, he said, you have to do something and you have to be more active about intensifying these conflicts and bringing them to consciousness. So he really started then to be a scientist. And whenever he would systematically, okay, you gather data in your inquiry. What's the problem? When did it start? What are the triggers? You begin to formulate a hypothesis about what the underlying conflict might be. And then you're going to test that out and use the patient's response to your intervention to either, okay, that's confirming my hypothesis. Yes, it's a conflict over competition or anger or whatever it might be. Or, oh no, that doesn't, it's suggesting something else. Okay, it must be this. Let's go there. And so it really is the scientific method. And then he started recording the sessions, which again was very unusual in those days, so that he could study it. And if he found something that worked in one patient, let's say, again, challenging that defense, not just interpreting it, but, okay, you see that, you see you're avoiding it, you're avoiding your feeling, that creates numbness and depression. You want to be free of your depression, so what are you going to do about that? I mean, are we going to face this or avoid it, right? So let's say he tried that with one person and it really moved things along. Then he would systematically try it in the next 10 cases.
So you already mentioned a couple of very interesting things. Maybe just to highlight, because it's so particular of this approach, the importance from the start of the videotape. And from the start, he's doing videotape and examining them. And how do you think this, in the early days, not even now, but how was this even a milestone for you in the development of the model itself?
For him?
Yeah.
Or for me? I mean, it was radical. I mean, think about it. He was an analyst.
Yeah.
I mean, this was totally radical. I mean, first of all, he wants to sit up face to face, no defense against closeness. And then he's videotaping and studying. And then he even at the end would bring the patient in to look at, he said, this was the turnaround session. Let's look at what happened here. I have my ideas, but what about yours? I mean, this is all so radical and so ahead of his time, right? Asking patients for feedback, right? People are doing that now, like Scott Miller, but as if that's a new idea. So I think that, it takes a certain personality type also to be so radical and to be willing to shun convention what really drew me to him was, again, this stand that he takes, stand for health, for capacity, for each person to actually be able to heal and be cured. We have abandoned this, and we have become content with helping someone manage their symptoms instead of getting to the bottom of it so they could be free of it. So he's very ambitious with his goals and then extremely hardworking, both himself and then urging the patient to work hard and to dedicate effort and to tolerate some pain and discomfort in the process to get growth. And I think it was this kind of thing that really drew me to him, because I was so sick and tired of this, what do you call it, that's happened in our field. Where people are just content to help people with their symptoms. I don't know. I wanted more, for my patients and for myself.
One thing that I remember that you wrote when you wrote with David Malin, Lives Transformed, the book, I remember that you wrote that most of, or maybe all of the major breakthroughs that innovations that Davin will propose were pre-interpretative.
Yes.
Can you tell us a little bit about this?
Right. So really, if you look at, again, traditional psychoanalytic method is mostly interpretation, where the therapist is listening, they understand what's really going on, and they tell the patient. And then the patient is supposed to have a big emotional response. Right, well, way back with Alexander and French, right, in 1946, They found out in their first investigation of whether it was possible to do short-term, right? And they compared short-term and long-term psychodynamic treatment at Chicago, right? They really found that the opposite was true, that the insight was the result, not the cause of therapeutic change. And they're the ones who came up with that whole notion of a corrective emotional experience. So something has to happen in the therapy between the patient and the therapist that actually evokes strong emotion, and then the memories come. We know this from state-dependent learning, right? You're much more likely to remember if you're in the state you were when the memory was encoded, right? So if the patient gets in touch with grief or anger, then suddenly those memories of where the conflict around that started come. And then, in most cases, actually, the patient makes their own interpretation or their own, which is so much better, right? Or even if they don't, you then are in the position at that point to make that link, that interpretation, and the patient is open to it, right? Their defenses are down, they're in touch with feeling, and that's when the interpretations, the links, and this deep understanding can really take hold.
So
go ahead.
now I'm wondering how it was taking this insight, basically. How was your experience of starting to actually see and practice with Evoluh and starting to do ISTDP? What was that first experience like?
Yeah, well, as I said in the other interview, when I got these techniques, right, when I studied with Evoluh and saw this central dynamic sequence that he developed, as a way of getting a really tight internal focus, identifying and intensifying that conflict, right? Looking at that conflict between the feelings that want to emerge and the anxiety and the defenses that are keeping it down. Managing so the patient shifts and gets in touch with this. I mean, I was just raring to go. And some of my first cases were really successful. I mean, it made sense to me. And I think also in the 20 years now that I've been teaching and training other therapists, I see that if the trainee doesn't have a solid foundation in psychodynamic theory, if they don't understand how the unconscious works, they're not going to be able to institute a treatment that's based on that theory. So since in the last 30 years, so many graduate programs have gone CBT and don't acquaint their trainees with this tradition, they really have a double job. Like at once they're trying to learn a technique, but they also have to learn the theory. And so it takes them longer.
Yeah.
And they also didn't already have those years of experience with patients in that more psychodynamic. So if you look at the people who've really become, Diana Fosha trained with Evoluh, Lee McCullough, John Fredrickson, was already steeped in psychoanalytic theory and had a lot of experience with patients and working with unconscious material before then getting a hold of these very powerful techniques. So I think that combination is really required to be consistently effective.
So, but when you start, did you start immediately to videotape yourself?
Oh, yeah.
Oh, how was that like?
I mean, again, it was great. We had to have these big old hunking things with the VHS tapes, and it was very expensive, I remember. Because they didn't have these handy cams yet,
Sure.
This was in the late 80s. So, at first, of course, it's a little embarrassing to watch yourself. But I think my passion and drive to learn this and to help people was so strong, and it's such a fabulous tool because you don't always remember everything, and also you never know going into a session, is it going to be great Is it going to be terrible? And so I also found that I just instinctively started to review both the best and the worst. So if a session went really well, I would go, wow, that was so cool. I mean, how did we get there? And I would immediately watch the whole thing. I think this is so important, and not enough people are doing this. They're not watching the best sessions and really getting clear about what's going right. They too much focus on what's going wrong and what's missing, and only watching tapes where they're struggling. And I think that's a real mistake, because you want to be building on your strengths and watching what works, as well as, of course, looking into what went wrong there. And the great thing about videotape is, even though in the session you can be completely confused, have no idea what's going on, you watch the tape, and in 5 minutes, it's so obvious, right? And so it's the best supervision ever, right, is to be able to watch that and then go back the next time with new clarity. So
this is a great deliberate practice tip, what you're saying. Mm-hmm.
Yes, and I think it is important not just to look at the tapes where you're struggling.
So one thing that I've noticed in your writings, and I think even you wrote in Lives Transformed about this, is that your own particular style is less confrontational than Evoluh's. I believe some people have this misconception, I think at least for you it will be a misconception, that this approach could be too confrontational for the client. I imagine this is a stereotype. So would you set the record straight for us about this?
Right. I think this is really, really important. Gosh, there's so much to say about it. So, first of all, what is it that we're confronting? Mm-hmm. Any therapist, to be effective, you must form a strong alliance with the healthy part of the patient, or the true self, as it were. You've got to be there for them and sort of rooting for them to become as healthy as they can, to become who they are, to be able to attach securely to others. And this is where, again, Evoluh's stand for the health of the patient and their potential, and against anything that would harm them or undermine them. So all the defenses and resistances, even though they originally come online as some attempt to help the child adapt or deal, which is important to acknowledge, right? They've long outlived their usefulness, and in many cases really backfire and create all other kinds of problems, most particularly the problems the patient is coming in for help with. Mm-hmm. So it is very important, actually, that you do this, we call it defense work, before we would ever challenge or confront a defense. You have to help the patient see it. Yeah. Right? Do you see, right, the way that you laugh off, right, this terribly painful feeling that's coming up? Mm-hmm. And then you want to change the subject. Mm-hmm. And you actually start to distance and cut off from me. I mean, do you see this? Now, I mean, in a way it's understandable because it's so painful, but on the other hand, right, you are running from yourself. And what happens when you do that? Yeah. They say, oh, yeah, I know, and then I get depressed, and then, okay. But that's serious, right? I mean, that's a problem. So what are we going to do about that? So once the patient sees that they're avoiding feelings, closeness, in a way that hurts them, we then put them at choice. Is that what you want to do? Mm-hmm. Right? It really is a confrontation with reality. We're not confronting the patient. We're confronting these mechanisms that are harmful. And we're also confronting reality. So many patients and therapists have fantasies, right, of omnipotence, or that I somehow can cure the patient, without their cooperation. And this is a reality check. It's saying, look, it's up to you. Uh-huh. But I cannot possibly help you if you don't open up to me. Mm-hmm. I mean, that's just the way it is. Okay? I don't, in fact, have a magic wand. Right? So if you want my help, you would have to be willing to open up here. and reveal what's really going
It's
on.
very straightforward, very matter of fact.
It is.
Yeah.
And so to me, again, when you're clear, it's a confrontation with reality. And we're confronting or challenging the patient to operate at their highest level, right? To face what needs to be faced in order to heal and to give up, right, these temporary sanctuaries, right, of hiding and covering up, in ways that hurt them. So again, this is all in the way of saying that if you, and we actually know this not only from psychotherapy research, but if you look at the research on teachers and students or parents and children, we response to challenge. Our brains grow in response to challenge. You actually have to induce moderate levels of stress and anxiety for an adult brain to grow. But you can only do that. You can only stir up anxiety and challenge somebody in the context of a trusting relationship. So you must attend to and develop an alliance in which the patient starts to trust you, right, that you know what you're doing and that you're actually a resource to them. And then you can challenge them. But if you start to challenge somebody before you've developed trust in an alliance, you're going to get a misalliance, right? And the patient is either going to leave or they're going to get even more defended. So I think there are a lot of misunderstandings about this whole
issue.
Yeah.
And one thing that's very interesting about ISTDP for me is the level of specificity that you described, and also the importance of actual technique. Because I remember even in Lives Transformed, you cite a study, a 2003 study, where of patients experienced in ISTDP. And they talk how they recognize that the therapist's technique was the factor most responsible for achieving the ends of therapy. And it was even more important than therapist's warmth.
Absolutely. This is so important to understand that it's not about having patients like you. And in fact, a lot of therapists have a big need to be liked. And it really interferes, especially with being able to do ISTDP or any, really focused, intensive work where the patient is going to have to face what they've been avoiding. And they've been avoiding it for a reason, because it evokes anxiety, it evokes pain, and yet it's necessary to the healing process. If you need the patient to like you, right, that's going to trump, excuse me, now I feel like I can never use that word, but it's going to trump your real purpose in being there and your job, which is to help this person, right? So you have to get over that need to be liked. The patient might even get angry with you, right? But at the same time, they're appreciating that you're willing to put yourself on the line and to do the tough work with them. We jump right into that. And so, I just think it's these very specific techniques of getting the internal focus. That alone, so many therapists waste hours and hours talking with patients about external things, about other people, about the system, about whatever, which, neither one of you can do anything about, and are actually ignoring the person sitting in front of you, right? It's how we are responding to what happens, right? And how we deal with our own feelings about it that's either going to lead us to health and to getting what we want, or to misery. And so having specific techniques to really create and maintain that internal focus, to deal with defense and resistance effectively, and then to really facilitate the multi-layered experience of intense emotion. Most therapists have very little training with this, and they're not good at it. And the research shows that the only thing they're good at is going into reduce emotional intensity.
Downregulate.
Exactly, which, maybe in certain cases is required, but in many cases our patients are so caught off and detached, you have to learn to do the opposite. How do you, right, get some emotional intensity going? So if therapists are both untrained but also themselves anxious about intense feeling, about tremendous intimacy and closeness, which is required, right, in the therapy, then they're not going to be able to be very successful with this kind of work. I think it's actually very, very demanding treatment. Um, and yes, it can get extraordinary results, but it also requires an extraordinary level of training and also of presence and engagement with
So
patients.
you're mentioning also something interesting, which is, and I remember even Alan Abbas writing about this, which is the role of how patients can deal with the actual intervention. And he even writes about how how different trainees seem to need some character traits, or at least to tolerate a lot of things to do this practice. Can you tell me about
Yeah.
your own experience about different trainees and how they are able to manage doing this kind of work?
Right. Well, it's interesting our timing here because I just finished a 3-day training block with a group who's in their last year now of a 3-year training. And they were reflecting and really talking about the enormous personal change that they have in many cases, their lives are completely transformed, from the inside out. They've made huge changes as the result of the training. And in many cases, people will say, I got more personal change from my training than I did even in my therapies. So as we're doing the training and supervision, we're watching their tapes, we're seeing where they're getting stuck. And especially in the second and third year, in the first year, okay, maybe they have no idea what to do, right? And we start to train them on what to do. And then when they know what to do and they're not doing it, right, it's usually because they're having some anxiety or they're using the intellectualizing defenses. They're joining or they're joining for some reason the patient in externalizing about that awful husband. And why is that and what's coming up in them? So it is very important to be looking at that, the personal factors. And these people, of course, the people who are willing to make this kind of commitment to the training are almost always very willing to really look at themselves and, how perhaps passive they are, or how they tend to take over and be too caretaking or people pleasing or whatever. So they're going to have to change some of their own character in order to be effective. And as they do, and this is something I tell my trainees on the very first day of training, I say it's both a warning and a promise. This training will change you and change your life. So yeah, we have to be willing to look at ourselves and how we are getting in the way.
Yeah.
So that's another thing that I think actually in ISTDP we haven't done enough of, which is to look at what is the therapist's contribution to the resistance. So they're always saying, oh, the patient is so resistant. And I said, well, and some therapists seem to get all these high resistant patients. I say, how can that be? Well, so resistant with you. They really don't seem to be so much with me or whatever.
Mm.
Right. So, what are we adding to that? So we really want to be able to look at both sides of the equation there.
So now you mentioned, and you are interested in psychotherapy expertise and deliberate practice. What is your personal perspective of what makes a psychotherapy expert? And I would try to ask you if it would be possible to try to be broad-ranging in terms of even theoretical modalities.
Yes, I think it doesn't really matter. We know that, whether you're doing CBT, ISTDP, but that you're passionate about it and deeply committed. We know that the best therapists spend 7 times the amount of time thinking about, reading about, talking about their cases and what they're doing in between the sessions. So like Tony Ruminari says, doing it in session, that's not what I mean by deliberate practice, okay? Right? It's what are you doing in between sessions? And so I think, people who are constantly reading and reading broadly. So whether you're doing CBT, ISTDP, you don't just read in your own little narrow, right? You're also reading theory, you're reading research as well as, so to me, those three things, what I call the triangle of competence, right? To be competent technically as a therapist, you also have to be deeply grounded, right? In theory, both of normal as well as abnormal development. And you have to keep yourself abreast of the research. And all three of these inform each other reciprocally. So again, whatever you're mastering, whether it's tennis, cooking, you're passionate about it, you're reading about it, thinking about it, practicing it, talking to other people. Masters are nerds. Okay. They don't have a balance. They're obsessed. And they're also highly ambitious. That's another quality of theirs. So they're not satisfied with getting, mild or moderate improvement. Like we want the whole Megillah. And so we push ourselves and the people we work with, right? Our trainees and our patients also, right? To be ambitious and to go for, complete remission, right? If that's possible. It's not in every case, but, so those are some of the qualities of the best of masters, no matter, and they're constantly learning, never done. And it's so interesting that research and they ask therapists about how effective they are. First, the alarming news, you probably know it. Those in the bottom quarter. So if you're just looking at their results, right there. So the bottom quarter rates themselves as being on the top. Mm-hmm. So they think they're in the top 25% when in fact they're in the bottom. And those who are in the top tend to think of themselves as kind of in the middle. Right? So they say, I'm doing okay, do some good things, but I have so much more to learn and I could get better. And so they have a lot of these seemingly contradictory, right? Ambitious and confident, but humble and open to feedback and always learning. So, no matter what you're doing, those qualities are qualities that you want to try to develop. Yeah. And some of it, I don't know. Can you make yourself passionate about something? I don't know. I think that's something you have or you don't, right? That you're just obsessed about this thing. Obviously you have it, right? You've got the bug. You want to be talking to everybody and it brings you alive. So that's really essential.
One nice compliment to what you're saying. I also love the research of Nissan Lee, which is therapist self-doubt is also positively correlated with outcomes. So that ability, like you're saying, of humbleness and self-doubt.
Absolutely. Anybody who says, yeah, I've got it, I always know what I'm doing, I never have, I'm like, whoa, yeah, not possible. We're going to be learning, hopefully, till we drop.
So you just gave me my favorite quote of the year, which is "Masters are nerds." So I would write a book just with that. I think that's wonderful.
And life intervenes. That's the other you underlined from earlier.
It's perfect for me. By the way, and you were saying that, of course, you read wildly for sure, wildly and widely. So, yeah. So was there any non-psychodynamic approach that had any particular impact in you?
Say it again.
Was there any non-psychodynamic approach that had any particularly lasting impact in your ideas or in your practice?
Again, I would say Paul Wachtel.
Which is psychodynamic.
When he integrated so beautifully, and so did Dollar and Miller before him.
Sure.
Right? How psychodynamics and behavioral can in fact go together. And that's the other thing that's consistent with Evoluh. He's not content to just talk with you about it. Okay, what are you going to do about it then? Mm-hmm. So we're actually encouraging people to take action, right, in alignment with their goals and desires, right? So I think that was a huge impact. Of course, I read Beck and was influenced. You know who else influenced me in my early days was Ellis, right? Who again is kind of like Evoluh, if you think about it. This very brash, rational emotive therapy, is what he did in the old days. Fritz Perls, the Gestalt people. And now, the somatic experiencing, right? These are all pieces. So again, when you look at the importance of emotional awareness and regulation, right, which David Barlow is now talking about, the unified protocol, this is one of the most important underlying factors in all psychiatric disturbances. There are at least 4 aspects of that, right? We've got the cognitive label. Can I think about and label what I'm feeling, right? I feel sad right now. And then can I actually experience that physiologically, somatically in the body? And once I do, can I become aware of what action tendency or impulse that generates in me? And then 4th, do I have the ability, if I choose to express that and share that with somebody else? So if you think about it, a lot of therapies focus almost exclusively on just one aspect of this, right? Just having someone mentalize or talk about the feeling. Someone else is doing somatic experiencing, somebody else interpersonal. But I think the more that you can facilitate the multi-layered experience, and also with each patient hone in on kind of the piece that's missing to fill that in for them. I think, again, the more flexibly you'll be able to implement these with other people. So I read very widely, and I'm highly influenced by all these folks, as well as the psychotherapy research and neuroscience. All of it.
How do you think, if you were to watch, I bet you do, but if you were to watch yourself practicing over the last 20 years, how do you think you've changed as a therapist?
Yeah, so again, that's interesting because I showed 2 tapes in this recent training, and they're probably 25 years apart. So one from when I first started, and one much more recently. So what I would say is that my work now is much smoother, much more integrated. So then it was maybe a little choppier, and also, I'm more relaxed also, as a person. So I'm probably more confident now, not just in myself, but really in the power of the unconscious. And what Evoluh calls the unconscious therapeutic alliance. This is the most amazing thing, this inner healing force in all of us, right? That once that gets activated, it's so fascinating to watch, right? How the unconscious will bring, the very material we need to be able to. So it's like, I can relax. I don't have to figure it out. I'm just working on defense and anxiety regulation and getting to feel. It will surface, right? So I really have confidence in the process. And I think the other things that I have really developed over time, like you were saying, Evoluh is associated with a more, like sort of a tough confrontational approach. And over time, it's not that I don't do that, but it's always paired with an appreciation of the healthy desire, what the person wants. So I think if you're just confronting defense and resistance without being clear about what the healthy alternative is, so say, because often people say, like, I don't want to do that, but I don't know what else to do. And in sort of traditional ISTDP, they would call that helplessness. Well, now you go helpless. Now you go this and that. Right? As if the person does know. And what I realize now is a lot of times they don't know.
So you help them create
right?
the direction.
Right. So I'll say, yes, what's the healthy alternative? So if shutting down and withdrawing is really exacerbating, right, your depression and isolation, what's the alternative? And they'll say, yeah, well, I guess to connect. Yeah, so do you want to connect here with you and with me? So I'm going much more also for what we actually want.
Yeah.
Then the other thing, which it has been heavily, I would have to say, influenced by Diana Fosha, who I have had, the great pleasure to know for a couple of decades now, is working in the same way with positive emotions as we do with, in ISTDP, there's a lot of focus on anger, pain, grief, guilt, and these are all very important. But just as important, right, love, hope, joy, pride, so when someone is starting to, hey, I feel good today. I say, wow, what's it like to feel good? How do you feel in your body, right? Getting these positive feelings up and running also. So I think those are just some of the things that I notice changing in my work over time.
That also seems like a change in the model itself now, starting to implement more this focus also of positive emotions.
Right. It's not that that's not there in ISTDP. It just hasn't been much of a focus, or it's maybe just kind of accepted when someone gets to, love and relief. But you wouldn't necessarily ask them, how do you feel that in your body? What does that want to do? And why not? Like, why we work with all feelings, right, in that same way. So I think it's just expanding on it. And the other thing, and this sort of reminds me of when Wachtell talks about, the importance of language and really giving the patient credit. That's another thing I do a lot, and I think much more intentionally in the last 10 years, where I'll say, so what you're telling us is, right? Not what I'm figuring out, right? Or the person will say, I guess I'm angry, but I don't know. I don't think I feel it at all. And I'll say, well, I think your hands maybe know something about that. Maybe this part doesn't, but look at what's happening, right? What's that fist feeling right there? So it's more and more just reflecting back what they are already telling me and showing me, right? So that I'm really much more focused on also building the positive capacity of the patient at the same time that you're going to call those, defenses and resistances into question.
So, Patricia, two last questions I have for you. The first one would be if you were to give some sort of, let's call it a healthy tip to any kind of beginning therapist, what do you think would be an interesting thing to try to do more routinely, like some sort of deliberate practice habit or practice?
Yeah, well, okay, so maybe I'm going to say something a little different because I know there are already, that's, a lot of people are suggesting that. And I think that that's fine and good. But what I have found is that if you're just practicing techniques and you're not spending enough time on your theoretical understanding and getting a real clear case formulation, that what happens is, okay, I can practice identifying and challenging defenses. I can practice regulating anxiety. But unless you have a clear understanding of each patient and you have formulated their case, a deep understanding of why it is they would have become symptomatic in this way at that time, and what's going to be required for healing, you're not going to know when to use those techniques, right? So I would suggest that it's a balance of really digging into the literature and reading, again, even in ISTDP, I come across people who say they've already finished a 3-year core training And when I begin to ask them about what they've read, it turns out they've never even read Evoluh. Never mind Freud and Fenichel and all the other people that his therapy is based on. And I say, wow, I mean, how can you practice a model whose theoretical base you know nothing of? So I would say really to balance that and make sure you're reading the classics. Read Malin, read Alexander in French. I mean, that work on the corrective emotional experience is so fresh. It's as if it was written last year. So I would suggest diving into some dynamic or whatever the theoretical base of the model that you're using. Because otherwise, you know, one of the analogies I'm making is like with a GPS, right? So if you're just learning a model, right, with all these steps and techniques, it works as long as the person is responding exactly as you hope they will, right? But if you suddenly come to a dead end or a river just washed out that bridge, and if you don't have a map internally, then you have lots of other ways you know you can go. Yeah. So I think it's really important to work, and we know also, going back to the research on the best therapists, they have superior metacognitive skills. So again, it's one of these dichotomies.
A balance between the
specific technique, but also the metacognitive skills, that you know why you're using them, when and with whom, because you have a certain understanding of how this particular person is put together, right? What's been missing, what they need, right? Instead of you're just doing a model, no matter who's coming to see you. And we know that, right, from all the research, that you have to have a model and you want to be systematic, but you have to be flexible based on how the patient's responding. So, yeah. So that's what I would recommend.
Well, the last thing I want to ask you, I don't know how much it overlaps, but I asked all of our other guests this, so I'm also going to ask you. What advice would you wish to have received when you were starting out as a psychotherapist?
Gosh, I just think I got such fabulous training, and I got so much mentorship, and I'm really just grateful for everything I got. So I don't feel like there were big missing pieces there. I mean, every step along the way, I think that issue of having at least one real mentor, and somebody, I know it can be, appealing in a way to try to learn from everybody. But I think especially in the early days, to choose a person who you admire, who is available to you, who's basically working in the model that you're interested in, and you really form a strong relationship with them. Get a mentor, somebody who's invested in you as a person, not just you learning the technique, but you, who you are, helping you develop as a person and to make, your own contribution. I think that's really, really important.
Patricia, I think that's a wonderful way for us to end. So Thank you so much for the opportunity to talk.
Oh, you're welcome. And thank you so much for doing this and for making all these interviews available to us. We get to know these big names, right? Wachtel and Foch, as people. So I think that's really wonderful. Thanks so much.
Thanks so much.